Firstly, thank you for inviting me, or originally Liara, so I'm filling in for Liara Tutina. So the slide deck I'm about to present is very busy in terms of there's a lot of information in there. I'll share the slides after this webinar. I won't be running through every single point on the slide. So some of the information there really is for backgrounds, but I'll take you on a guided tour really of a bit about Snomed Ct and also a bit about Snowmed International itself, which is important to understand. So I'm going to run through a bit about an introduction to Snowmed, a bit about the value proposition, and then we'll see how far we get with going through the case studies. So some of them, there are quite a number. If I don't get to go through them all, then they're certainly available, and the level of detail in there will help you to understand as you read them after this webinar. So a bit about Snowmed Ct and a bit about Snowmed International. So first of all, Snowmed International, we have a mission statement, as all organizations do, about sustainably producing global clinical vocabularies and other services that enable clear exchange and analysis of health information for all. The real key to that is the sustainability bit, or sustainably. It's important that whatever clinical terminologies you're looking at is sustainable and can be used over time and doesn't change, particularly to support the ongoing management of clinical issues that patients have over time. Our vision, so by 2025, clinical terminologies will be used globally and will result in better health and improved patient outcomes, supported by one language of health. And I'll touch on this one language of health in a couple of slides' time. So we wrote this vision statement before the pandemic. One of the things which the pandemic has taught us all globally is the importance of using clinical terminologies, using clinical information, using clinical data to make meaningful choices and to create meaningful knowledge out of clinical data. And the ability to do that quickly is obviously currently incredibly important. So what's Snomed Ct? Well, broadly speaking, there are three main components to Snomed Ct, which are over on the right-hand side here. They are concepts, descriptions, and relationships. So Snomed Ct itself has over 350,000 clinical concepts currently. And those range from things that you would normally think of in terms of procedures, both surgical procedures, diagnostic procedures, clinical findings, both in terms of the findings that a healthcare clinician would make within about that patient within a healthcare episode, but also in terms of symptoms, so the patient reported findings, if you like. And then also things like pharmaceutical products, substances. There's a lot of concepts and broad coverage within Snowmed. All the concepts are organized into hierarchies, and they're all linked through relationships into polyhierarchies. So what I mean by polyhierarchies, if you think about looking at a view of something like ICD-10, so a classification, you have single hierarchies focused on a particular aspect. Snowmed doesn't work like that. It enables one concept to fit into multiple hierarchies. So it's particularly important with things like, with the example that I've used, so I've just been doing a previous presentation, was looking at viral pneumonia. So viral pneumonia, you need to identify that it's an infectious disease, it's caused by a virus, but also that it's a pneumonia, so also it's a respiratory disease. So Snowmed will allow that flexibility by allowing polyhierarchies. Descriptions, so all those concepts though are either, as should be fairly plain from my accent, I'm based in the UK and my normal language is English. So even within just using English, there are the requirements for clinicians to refer to things in different ways. So in my background, I've worked in cardiology previously. So things like, when you talk about a myocardial infarction, well, yes, but it's also referred to as a cardiac infarction, an infarction of the heart, or a heart attack. So the ability within Snowmed to allocate synonyms is important. Descriptions are also then used when we translate Snowmed into other languages. So those descriptions then can be available. So at the moment, I cover Europe, so it's common for me to look at descriptions in French, in German, in Dutch, Danish, but all those individual descriptions are held within Snowmed. The relationships are then allows you to associate things, concepts together, and they support knowledge representation, but it has to be in a way which a computer can process it, and Snowmed provides that functionality. So this is what I mean about a busy slide. So I'm not going to go through all of this, but to give you, the idea here, using my previous example that I said about viral pneumonia. So viral, if you look at something like viral pneumonia up here, so viral pneumonia within Snowmed is modeled with a causative agent of virus. And that causative agent in an EHR system can be refined using the hierarchies of virus within Snowmed to identify a particular virus type, if that was the case. Viral pneumonia is also modeled with a finding site of lung. And you'll find out then that if you look, so this is almost the wrong way around in some ways. So this would be the parent concept. So the parent concept is infective pneumonia. That's modeled itself, has a parent of infection, but it also has a parent of respiratory disease. And infective pneumonia will have also be modeled with a finding site of lung. So if you have a pneumonia, it's always in your lung. You can't get a pneumonia anywhere else. So Snowmed really, it refers to itself, and other people have referred to it as a core reference terminology. So when we talk about controlled terminologies or vocabularies, the key paper, which people always refer to, was something written by Gmdn, back actually in the late 80s. But it identified 12 features which were important for terminologies to achieve, if you like. And really some of them, Snowmed actually meets all of the 12 features outlined in Gmdn's paper. If you look at things like classification systems, well, some of the classification systems, so ICD-10, meets about 4 of those 12 criteria. But then within Europe, Europe back in the early 2000s did something called the Sepsis Ct study. And what the Sepsis Ct study does, it was funded through the European Union and really looked at defining 4 different types of terminologies which were required to deliver healthcare. One being reference terminologies, the other core reference terminologies, aggregation terminologies, and then user interface terminologies. And the Sepsis Ct study concluded that Snowmed was a reference terminology, but its key role, really because of its broad coverage, was really to act as a core reference terminology. And I'll touch on that in a couple of slides' time, and particularly in the use case, the example use cases, which will give you some idea why that is important. So, comparing, we'll do a compare and contrast, if you like. So Snowmed itself in the middle here, as I've said earlier, has about 350,000 concepts. If you look at some other terminologies which you'll be familiar with, so something like LOINC. So LOINC looks at primarily looking at laboratory findings, although they're developing into the clinical space. But LOINC has about 93,500 concepts. But then things like INSERM. So INSERM is an orphanet, is the classification of rare diseases. That has about 7,000 concepts, but it's only focused on rare diseases. You've got things like ICF. So ICF is the International Classification of Functioning. So that, exactly the same, is focused purely on functioning and abilities, which is published by the WHO. That has about 1,400 concepts. And you can see, I'm not going to go through all of these, but you know, some of these will be focused in particular areas. Some are bigger than others. But all of them are included. If you look at the content areas, all those content areas are included in Snowmed. That doesn't mean that everything in each of these separate terminologies is in Snowmed in the same form. But it does mean, broadly speaking, the areas covered are covered within Snowmed. And to give you some example of how this works in Australia, so Snowmed International produces and publishes an international version of Snomed Ct. And we publish that every 6 months, which happens to be in January and July of every year, and that never changes. But each of the member countries which form part of Snowmed International can then take that international release and extend it for their own purposes. So in Australia, you can download the Australian edition of Snomed Ct, which includes the international release, but also includes the Australians, medicines terminology, and about 90 reference sets, so 90 subsets of Snowmed, which have been created to support clinical care. And it's used in all healthcare settings, all healthcare sectors, and it's used for clinical healthcare record documentation. Because it includes the Australians' medicines terminology and the particular requirements around delivery of medicines terminology and to reflect the rate of change, it's released on a monthly basis. So even though, you know, across a 6-month period, if you like, the international release content wouldn't change, the content within the Australian extension, if you like, will, and that will change and be updated as you go through that. So with Snowmed, so what's unique about Snowmed, if you like? So it's a core reference terminology. It's integrated to over about 20 other clinical terminologies and classification systems now. And that's an ongoing labor of love for Snowmed International to work with other standards organizations and to build those links, with the idea that really, you know, if you're in a healthcare organization and you require a terminology, then use the core as Snowmed. So record all your data in Snowmed form, and then use other terminologies for other purposes, particularly around analytics, particularly around reporting, providing additional clinical detail, which would never be included in something like Snowmed as a core reference terminology. With all terminologies, there's a phrase which was used by a colleague of mine a long time ago, which is content is king. If you think about, you know, healthcare across all specialties in healthcare, you need broad coverage of everything. So it's not about making sure that you have all the correct surgical procedures, or it's just about diagnosis. you need content in all areas. Therefore, content is king. You need a lot of content. And Snowmed provides that, and provides really fine-grained clinical terminology. It has 3 or 4 times more content than even something like Loink or other similar terminologies, and certainly more than some of the terminologies which target narrow subdomains. Oops, oh, sorry. But it's also built around this idea of semantic network. So Snowmed is machine readable, which is important and really built on a system which allows the computer to make sense of those terms, to use them, to transmit them. So one of the things which people always notice about Snowmed is if you're used to particular classifications, you can memorize from other classifications what particular codes are. And those codes tend to have meaning. So things like the example of viral pneumonia. So viral pneumonia in ICD-10 is J12. And you can remember J12, and the J means something. It means it's a respiratory type of disease. But Snowmed itself, the codes are meaningless. So, well, they're meaningless to humans, rather. So if you look at a Snowmed code and it's 77 444 698, it doesn't mean anything, and you're not expected to remember it either. What you are expected is to interact with the descriptions, so the things which clinicians would normally expect to see. The codes then are used by the computer, either in terms of sending that data from point A to point B, or using it for other purposes within the application itself. It has to have broad use of context, so Snowmed's commonly used for documenting things like problem lists, procedures, clinical findings, but it can also be used in other areas as well. And the same Snowmed coded data, which is recorded locally, can then be used for interoperability purposes, analytics, research purposes, both locally, nationally, or also internationally, which is becoming more common now. So if you think particularly in terms of the pandemic, a lot of that, the knowledge, if you like, about how COVID was spreading, about what treatments were successful, particularly about the vaccine, the vaccine rollout, issues with vaccine. A lot of that relies on data and large amounts of data being shared across countries. There are also, there are some countries which have taken the step to nationally mandate Snowmed. So one of them being my own country. So the UK has mandated Snowmed now since 2018. Australia has done the same, so has the US. It's important, not necessarily, well, from my perspective, it's obviously important to mandate Snowmed because I work for Snowmed, so I have a vested interest, if you like. But in terms of looking at it from a national perspective, what you're really looking at doing is trying to get some consistency in the way data is recorded within that country. Once you have consistent data, a lot of the requirements down to national level will fall from that. The ability to share data, make sense of data, communicate data, national reports can come in standardized formats. A lot of that is driven by this idea of having a national mandate for Snowmed in this case. So what about the Snowmed value framework? So if you've got Snowmed, what does Snowmed bring to the table, if you like, I guess? So if you look at this in terms of a CIS, so clinical information system, or a health data analytics platform, or some interoperability solution that you're implementing locally. So what Snowmed supports really is, one is around the system quality. So not just in terms of the content, but also in terms of the structure of Snowmed. It will support a lot of those internal processes within the system itself. Because it provides granular data, granular descriptions, it also improves the quality of the information which that system holds. Because you then have access to better support within the system, better quality data, the service you give, it will then support service quality. And that then has an impact on, systems will be used more, the users of those systems will be happier. And that then brings net benefits. And that's quite a common framework in terms of bringing anything, any type of change. But it tend to follow that process. But the net benefits then can be varied. So it depends on the system, it depends on your focus locally. You'll be glad to know I'm not going to go through all the detail on this slide. But broadly speaking, right, so Snowmed here, within it is integrated a number of other terminologies and standards in terms of DICOM and HL7. That is either reflected by content, so there are, we've effectively added content to support particular use cases. In terms of other things like I say, like DICOM, like HL7, which are standards in their own right, if you like, a lot of the support for those are built in with implementation guidance, and indeed something like HL7, we have a joint working group at the moment, which is called Snowmed on Fire, looking at how Snowmed is used within fire profiles, really to come up with a definitive guidance of how that works, but also to identify any content issues or changes to Snowmed which need to be made to improve that. All of that then, as we've said before, gets fed into some kind of EHR, clinical information system. And that will then support the patient journey. And if you think about a patient journey, a patient will have numerous interactions with healthcare professionals all through their lives, going from birth to maybe vaccinations when you're a teenager. If you're female, you might come into contact with maternity services as you go through life. You'll have complications, you may require surgery, you may see your GP. But all that information about you really does need to follow you through the healthcare system. So it's not just information which is available to you when you go and see your general practitioner, your family practitioner, your local GP. It also needs to be available when you go into hospital, and particularly because hospitals tend to deliver more major interventions. Arguably, it's more important in hospitals than anywhere else in some ways. But the net benefits that then come out the other end of this. So by both collecting that data and having the ability to share that data, then leads to better health outcomes, better service, patient service outcomes. So patients will get better service from healthcare itself, and also better outcomes. So they're better informed, the treatments work better. If you think about from a population point of view with health promotion, then health promotion, you can support health promotion with large amounts of data to see whether things work, and then refine those health promotion activities to better meet the requirements of your population. And it gives you increased health system value. So there's more value for the resources going into the healthcare system itself. So we always talk, particularly if we look at this in terms of talking with governments, is looking at what the value proposition is. So if you're going to adopt Snowmed, despite everything I've just told you, why would you do it? Why would you implement Snowmed in a country? Well, if you look at it from the different perspectives which we have around here, so from patients, so one of the things which patients are becoming more demanding in some ways And yeah, thanks to the internet, patients have more knowledge about their conditions, some of their health issues than ever before, because the knowledge is out there. And some of that will help them around self-care. But when they come into contact, when they interact with healthcare organizations, healthcare clinicians, they're more knowledgeable and they want to see their own record. They want to see what's written about them. They want to have a better understanding of what's going on. Snowmed allows them to do that. One, because it allows you to add synonyms so you can refer to things like heart attack rather than myocardial infarction. But it also gives you insight in terms of how that's implemented in clinical decision support systems. There are a number of ways that feeds in. It also allows them to, because they're better informed, it allows them to collaborate really on their own care with healthcare providers in a far more meaningful way. From healthcare providers' point of view, it allows healthcare providers to improve patient outcomes just because they're more knowledgeable. Healthcare providers will be more informed and have a better collaborative relationship with the patient, particularly when it comes to critical care decisions. And it allows care providers to give the best possible care, which is what all healthcare providers are aiming to do. Otherwise, they wouldn't be in the business they're in. But from an implementer's point of view, so if an implementer's taking Snowmed, so it allows them to, as I stated earlier, collect data once and then reuse it for a variety of different purposes. And it enables them to support that information, or the information needs, the information requirements of a number of different stakeholders, whether they're care providers, policymakers, patients or citizens. If you like, you can wrap that data up in particular packages which meet your audience's requirements. So Snowmed does and help vendors sell their products. So we have now Snowmed used in products in over 80 countries globally. And particularly with the advent more of computer apps, it's also through app development really opening up a lot of new markets for software products. So vendors have quite a big interest in using Snowmed, both in terms of what Snowmed does, but also supporting them in where they want to be in terms of developing their own product range. We also have a number of collaboration partners. So the collaboration partners we have professional associations who contribute to the clinical knowledge within Snowmed and help to maintain its clinical integrity, so to keep it clinically fit for purpose. We also have collaboration partners who are standards organizations that I've touched on, so things like HL7, who will either contribute artifacts or contribute knowledge and collaborate with us in terms of how their standards are implemented with Snowmed. And then for researchers and knowledge producers, well, one, it provides them access to a large amount of granular data, which researchers will love because it improves the insight. But also the structure of Snowmed allows them to leverage some of the ontological basis of Snowmed to support some of those, the analytics activities that researchers will undertake. The proposition, if you like, so the members and providers I'll touch on separately. So really for members, so the reason countries join Snowmed, so what joining Snowmed means from a national perspective is that we license Snowmed at a national level, normally through a central body like a Ministry of Health. We base the membership fee of the country is based on GDP and based on the country ranking, which is published by the World Bank. So basically the bigger the country, the bigger your GDP, and the more successful you are as a country, the more you pay as a member of Snowmed as a country. And obviously the vice versa is also true. So developing countries, we either charge very minimal national licensing, or in terms of some countries, we also have a public good license. So we effectively allow Snowmed to be used in certain countries free of charge. Hello. But by taking Snowmed at a national level, it allows free use of Snowmed for any organization, any member, any vendor, sorry, within that country. It also allows any vendor in particular within that country to use Snowmed free of charge in any other member country, of which at the moment there are 40, this has actually moved on, there are 41 countries internationally now that are members of Snowmed. If you look at what becoming a member means, so one is the free use within your country, but also we've been growing membership now. So there's been since 2007, which is when, well, the IHCSDO, so the International Healthcare Terminology Standards Development Organization, was formed, which uses a username of Snowmed International now, because the other one was too long and complex. But it's seen about a 25% annual growth in the number of international members. So we've had a steady growth of members. So when we started back in 2007, there were 8 founder members, and that's now increased now in up to what, 18 years now. 18 years? No, my maths is wrong. In 14 years, up to 41. But also, the case for investment. So where Snowmed's been deployed, you can also see a benefit, both in terms of the rate of return and also in terms of some of the cost reductions. So it's certainly worthwhile people doing it. And one of the reasons why we've continued to grow membership is because that's the case. We in some ways we'd rather we grow gradually so we can support countries when they become members. But it has gradually joined over time. For policymakers, so this is particularly true in countries which are using Snomed Ct and at a particular national level, where countries can conduct data analysis, look at mitigation strategies, particularly in the current climate, report on COVID-19, so coronavirus. And certainly countries that were using Snowmed were reporting on coronavirus back in January last year, even before the WHO declared there was a global pandemic. So it's certainly something that's really an underlying important aspect for policymakers, is that ability to have rapid access to granular data to give them that insight. If I look at, particularly for policymakers at a more local level, so one of the large hospitals in the UK is one in Cambridge, so Addenbrooke's, the University of Cambridge Hospital Trust. They have implemented a number of different implementations, including an organization-wide implementation of a single EHR system. They also use Snowmed. They've also changed a lot of their processes and have gone for HIMSS accreditation, which they've recently achieved. And one of the things which they implemented was the idea of implementing a sepsis protocol within accident and emergency. And the sepsis protocol itself has a number of triggers. And those triggers are all Snowmed encoded. And what they found is by implementing that protocol, they've seen a drop in sepsis mortality of about 42%. And sepsis, as any of the clinicians on this call will know, one, it's a very serious problem, but it's also a very serious problem which rapidly becomes a serious problem. So it's something which you need to identify very quickly and treat very quickly. And by them using Snowmed within the sepsis protocol, they did an analysis by going back through all the patient records for 1 year, which in this case was 2018. So they did this really as part of the HIMSS accreditation. But they analysed all those individual patient records and found that by using the protocol, using the Snowmed codes in it, the triggers, they'd saved 64 lives. So 64 people are alive today that if they hadn't used the sepsis protocol, they hadn't used Snowmed encoded data within that protocol, would not be alive. Then, if you look, that's in terms of lives. If you look at what North York General Hospital did in Toronto in Canada, they looked at Snowmed enabling order sets. So, a large academic hospital, a lot of tests. So a lot of blood tests, a lot of radiology tests. Just by Snowmed enabling the order sets, they saved effectively 31 million Canadian dollars over a 6-year period, not by preventing people accessing them, but just by eliminating errors. So either removing duplicates, so making that data freely available so people could see what had been ordered and didn't order the same thing twice, or also ordering things which were just clinically not required. So just by eliminating those errors, which is quite a big jump. So 31 million Canadian dollars goes a long way. So I'll see how far we get with these case studies, and I'll try and allow for time at the end. So I might run through a few of these and then we'll stop for questions. So looking at where Snowmed's used, so I'll go into the first one. So a bit about the overview of case studies. There are a number of case studies in here, some of which you'll be aware of because they've used Snowmed for a long time. So things like Kaiser Permanente have been using Snowmed now for near enough 18 years, so even prior to Snowmed International and the IHSDO. North York Hospital I've talked about, as is with Cambridge. But then there's also things like Odyssey. So Odyssey is the big global research collaboration. And we've been working with Odyssey, which build in Snowmed into their OMOP and clinical data model. And I'll touch on that in a bit more detail. I'll definitely do the Odyssey slides. But then there are things like the Veterans Administration in the US, Australia I've touched on, Honggu in China, particularly related to COVID surveillance, and then Queensland and Barts Hospital in the UK. So a bit about the VA. So the VA, the Veterans Administration, big in the US, provide healthcare support to veterans, so all the ones coming out of the armed forces. They have a clinical information system called Vista, and Snowmed is embedded within Vista. And it allows both into the Vista system, but also the patient portal, which feeds into it. It costs about 3.6 billion to actually implement. And it's currently used in 1,200 healthcare facilities and has just short of 500,000 users. But one of the things they found by doing this, one, it has the highest user satisfaction levels in the US among any US clinical information system. So the people that use it like it, and like it a lot. The adoption, so it's adopted now in 100% of all their organizations. And one of the things they found is that by implementing it, they've seen a drop in 65% in adverse drug events. So, giving either the wrong drugs or giving drugs which a patient reacts to. That's quite considerable, because not only is that a 65% drop, there are some impacts by reducing that. So if you have an adverse drug event, they may be very severe. So the ultimate worst case scenario is that the patient dies of anaphylactic shock. But even if that isn't the case, then you've got prolonged periods in hospital, prolonged additional treatments, all of which has a cost implication. It also saw a 27% drop in duplicate testing. So just the fact that you have clear visibility of the tests that have been done, and you don't do the same thing twice. And then there are productivity gains. So people work better because you don't have to keep pulling charts down to find the latest information. The break-even points, so from when this was implemented originally, they found it was in 2003. So although it sounds a lot when it was implemented, the benefits came very quickly. And by 2007, so this is going back quite a while, they were looking at annual benefits which were 3 times greater than the annual costs. So it definitely pays its way in some ways. So with Kaiser has a similar system in place called Health Connect. And Health Connect has been implemented, as you can see here, back in, well, it was driven by the change in CEO back in 2002. But they found exactly the same thing. So, more efficient inpatient and outpatient care, 24/7 access to all the patient records. And Kaiser, as well as Kaiser having hospitals, Kaiser also has primary care clinics. So the ability to share that data across both hospitals, clinics, and geographical locations. So Kaiser covers quite a large area of the US. The same with the Veterans Administration. There was elimination of duplicate tests and improved patient engagement. So one of the things which Health Connect does is allow the conversation between the clinician and the patient. One, because they can see what information is recorded in the system. And then patients don't get frustrated by having to provide the same information every time. So it becomes a different conversation where, rather than, are you allergic to something? What drugs are you on? When you pull up on the screen, well, these are your allergies, have they changed? These are the medications, have they changed? So it changes the interaction with the patient. I'm going to skip that one, although you can read that when I share the slides. With the North York General Hospital, they implemented evidence-based order sets. And one of the things they found is that, firstly, the system they're using now has moved clinicians onto adopting a single system, which is important. Because they're using evidence-based order sets, so it's not just about ordering a single blood test, but you might want to do a screening for patients with MRSA. So what does that mean? And there may be blood tests in there, there may be histology, microbiology tests in there, but all of those are put together, and then the clinician just clicks and they're automatically ordered. So one of the things they found is that things like turnaround time for antibiotics has improved by 83%. Preventable mortality from pneumonia and COPD exacerbation dropped by about a half, just because the patients were matched to the correct order sets and had the correct test done at the correct time. And similar to when I mentioned about Adam Brooks at the University of Cambridge doing the review of sepsis, they looked at patients over a 5-year period, and just by implementing evidence-based order sets and getting Snowmed underpinning those order sets, you save 120 lives just simply by changing practice. Similar in a sense to the sepsis example, but they were looking at giving appropriate prophylaxis against VTE, so against thromboembolisms. And just in terms of the change in practice, they saw about 40% reduction in the number of venothromboembolisms. Actually, I'm going to miss out and just touch on these. I'll make available after, so you can read them yourself. But the one I did want to mention before we stop for questions is Odyssey. So Odyssey is an international network of researchers and a network of observational health databases. And the reason why it's important about the network, what Odyssey doesn't do, or what it's avoiding, is the idea of transferring large patient data sets around the world because of all the implications that go with that, particularly around patient privacy and data curation. So what Odyssey does is allow researchers to define particular queries which are then run locally, and the results are shared internationally. And to do that, they use something called the OMOP Common Data Model. So they have a standard terminology which is linked to, or has other terminologies linked to it. That means that and Snowmed is the central terminology within the Common Data Model. It means that if within the Odyssey network, if you're running a query against a Snowmed system in the UK, and you were looking at running the same query in Malaysia, but the Malaysian hospital runs on ICD-10, through the Common Data Model, you can take the data in ICD-10, run the query which transforms it into Snowmed, and then share the Snowmed data across the network, across the Odyssey network, and allow comparisons then between your data and data from anywhere else globally. And I mean, these are two examples. There are a lot more of examples about what Odyssey has been doing. But one of them, particularly linked to the COVID question, I guess, is looking at a safety study linked to hydroxychloroquine, which they did globally and got the data and the analysis done in 4 days back in March 2020. And by doing that, so one, they did it very quickly, but they also reviewed the medical history of just short of 1 million patients from 6 different countries. Now, if you're trying to do that by sharing patient data sets, one, it would take you a lot longer. It would also take you a lot more computing power. So really the approach they're doing is just a reflection of where we are currently in healthcare in terms of data, but also in terms of those requirements, wanting answers and wanting answers quickly. The same with, back in the year before, so back in 2019, there was a hypertension study, which compared chlorothiazide and hydroxychlorothiazide for treating hypertension. They did it across 3 large observational databases of patients in the US, but then looks at really informing the treatment guidelines. So making sure that the treatment guidelines currently, one, were correct and worked. And one of the things that came out of that study is that patients taking chlorothiazide were 3 times more at risk of developing low levels of potassium and were at greater risk of electrolyte imbalance, kidney problems compared to those taking hydrochlorothiazide. Now, So by knowing that, you can then clinically do something about that. So you can actively monitor their potassium. You can give them additional potassium either in the form of drugs or maybe change their diet, so increase their intake of bananas. And certainly monitoring those and monitoring the blood tests just gives you a more way of actively managing those patients going forwards. Right, now I'm going to stop there and really just move to the end here and really open this up to questions. So we've got 5 or 10 minutes at the end, so I'm happy to take questions, and then these slides I'll make available and you can access these slides and go through them at your leisure. So over to you. Yes.
Well, thank you. I'm Dr. Bunchai, Dr. Ian, for your very interesting. I have several questions on that. I think we have a very short time, so I will go very quick on the question. I have 4 questions. In your slide, you show the Snomed Ct International and bigger data set is the Snomed Ct Australian, and you said that they include the AMT into that. My question to this is that how they Snowmedize the AMT. To my knowledge, that at first the AMT use a different dosage form with the Snomed Ct International and other attributes.
So particularly with the drug work, so we've been going through a process now of updating the Snowmed drug model. So there are 2 things impacting on that. One is what you're referring to around feedback from members. So particularly with AMT, with RxNorm in the US, with Gmdn in the UK, for example. But there's also large changes in Europe and coming out of ISO, so the International Standards Organization, looking at using IDMP and then how that links to EDQM, so one of the international standards for dose form. So we've been updating our model, and both in terms of updating the content in Snowmed, but also in terms of updating the implementation guidance. So if you're taking Snowmed International, the international version, and you are linking that to your national drug dictionary, we give you some guidance about how to do that and what you need to link in terms of dose forms in particular. But then also, all the issues with combination products that come out of that. So, the drug area is complex, it always will be, but we give you some guidance and we've updated our model to align with that internationally.
Okay, so what you mean right now in Australia, they will not use the AMT anymore, they will use the Snomed Ct
No.
Australia with the AMT, or they will use both?
No.
It depends on the...
They use both effectively. So what happens with something like AMT? So if you think of this in terms, I guess the easiest way to think of it, think in terms of the Snowmed International release providing generic drugs. So something like it will provide you with amoxicillin, and it will give you a model which allows you to refer to the dose form. What it doesn't do is provide you with some of those combination products which will be available nationally, or the fact that you have amoxicillin in packs of 30 made by Ciba-Geigy. All of that level of detail is held within a national drug dictionary. So what AMT does, AMT provides that level of detail, but links it to the international release of Snowmed. The reason you link it to the international release of Snowmed, one is the fact you can then start to access other hierarchies within Snowmed. So you can link then the drugs you give to allergies. So you can start linking it to substances. You can start linking those drugs to diagnosis, which you can't do if you're only accessing a drug dictionary.
I understand that. And I looked through the Snomed Ct International, and it seems you explained that the Snomed International will only provide at the substance level, not the combination level.
Yes.
DMD and AMT is the same, doing the same thing, include this RX norm?
Yeah.
Okay.
And RX. So RX norm is going through the process of updating their links at the moment. DMD already have links, and AMT obviously does, because I've showed them to you earlier.
Yeah, but earlier, I think 6 years ago, I heard that DMD had already developed before the pharmacological model of the Snomed Ct developed, and they have to Snowmed 9. So they will use both DMD and the Snomed Ct with the pharmacological. Are they still doing that, or they just seamlessly integrate and use the Snomed Ct in the UK?
So DMD and Snowmed have now become integrated. So yes, so the model they were using originally back in, well, it was created 8 years ago actually, but yeah, 6 years ago was to keep them as two separate but linked terminologies. Mm-hmm. The way they're looking at the implementation now in the UK is more about implementing a single terminology, which includes DMD and Snowmed effectively.
Yeah. And could you elaborate more about the? I saw you in the slide that you integrate the Gmdn and the OrphaNet with the Snowmed Ct. How you integrate it matching perfectly, or what kind of the thing that we should do? Because of Thailand are going to adopting the Gmdn, and we also following the Genomic England for the rare disease terminology. To my knowledge, in Thailand, we are also looking at the AlphaNet. So could you please elaborate more about this integration?
Okay, so AlphaNet and Gmdn mm-hmm. are to a lot of organizations in terms of we collaborate with them to make sure that we have the correct content in Snowmed, but also to make sure that people who are implementing those other terminologies can work seamlessly with Snowmed. So I'll deal with them separately and I'll explain why. So in the terms of AlphaNet, so in terms of rare diseases, if you go on the AlphaNet database, what you will see is there is a term. So there's a term for the rare disease itself. And then there is a description identifying case studies around the world which relate to those diseases. And then linked to that will be links to research papers and everything else. Now, in terms of Snowmed, we will never include the huge text descriptions which are in AlphaNet. And equally, we won't include the links to research papers. But what we do is make sure that the term itself is included in Snowmed. And that when it's included in Snowmed, the definition which is in the text in AlphaNet, we define that in a computable way within Snowmed. Mm-hmm. So if you're looking at a rare disease which relates to a child's kidney, mm-hmm. we model it with the findings, you'd have the AlphaNet term, but you'd have a finding site of kidney. And we might even refine it further to the fact it was linked to pediatric kidney, not just kidney. So the process we're going through, we've done now the majority of AlphaNet. We've got a remaining 1,000 codes, which we're looking at currently. So AlphaNet itself is about 7,000 codes. So we've done about 6,000 codes effectively. We're working with INSERM, who are the ones who produce AlphaNet, to also produce a Snowmed to AlphaNet map, which would then allow you to have a computable map, which you could implement within a system to take you actually both ways. So it allows you to go from Snowmed to AlphaNet, to query AlphaNet, or AlphaNet back to Snowmed. And we will publish that. That's just part of the release, which will come out with Snowmed. In terms of Gmdn, so Gmdn is a bit different. So Gmdn we've had an agreement. I've been working with Gmdn now for 7 years, 6-7 years. With Gmdn has an underlying model for the way they represent things. Some of that model includes what we would refer to as grouper terms. So there's certain things in Gmdn which don't refer to devices, but are required in Gmdn to organize those devices. We don't include those in Snowmed because we don't require them. What we do though is take the devices from Gmdn. We then model them, place them within Snowmed, within a device's hierarchy, and then use that information either to define other concepts in Snowmed or with implementers to allow implementers to access them. And we provide a linkage between Snowmed and Gmdn as part of that. We're in the process of developing a computerized ontology model for devices, which when we do, we'll implement that within the devices hierarchy within Snowmed. There are some challenges about that with devices in terms of identifying what axes you use to define those devices. So, things like, there's obvious things like, devices, so device site, so where do you put the device? There are other things linked to it around sterility, so whether it's sterile or not. But then when you get beyond that, there are a lot of different things we could include, which may or may not be useful to people using it. So it really is trying to get some feedback, get use case requirements on what that model would look like, and then for us to implement it.
Okay. And the last question, I think, I know that the Snomed Ct provide GPS, the global patient set, for free. And how it's being used now, and what is the use case, and which country using it? So can we use it as a kind of the pilot to show our policymaker? I am the advocate of the Snomed Ct for more than 10 years, but still not success to convince our policymakers.
Okay, so the global patient set came out of collaboration with HL7. So HL7 have something called the International Patient Set.
IPS.
IPS. So the IPS was developed to support cross-border care, originally on the back of work which was done in Europe, called something called Trillium Bridge, which was looking at sharing data between Europe and North America. But then it got broader utility and broader take-up. So because the HL7 is available globally, we wanted to make Snowmed codes available that could be used in that way, which is why we came up with the global patient set. What the global patient set does, though, it only gives you the Snowmed concept ID, and it only gives you the description. So if you were looking at recording against a patient, they had diabetes, it would give you a computer code and diabetes mellitus. That's it. It doesn't give you any hierarchies. It doesn't tell you how it's modeled. There are no attributes, which means if all you're doing is transferring data from A to B, so from one site to another, that's fine. You don't require anything. If I look at some of those case studies that I mentioned, where you're looking at really using Snowmed for analytics purposes and getting those benefits in terms of saving lives, saving money, looking at restructuring the way you deliver healthcare, you cannot do that with the GPS because the GPS isn't designed to do that. It was never designed to do that. The GPS will keep under review, so the GPS may well gradually grow. So things like when we created the COVID codes, we made the COVID codes globally available because it was in a global interest for that to be the case. But the GPS will never grow that much. It will grow based on short-term particular requirements such as COVID.
Okay, thank you very much. I would like to give the floor to another questions. Any question from our audience? Ian, Ian, please say hello to Laila. Laila is, we are collaborate with Laila and many people in the Snomed Ct International. But in Asia, we're trying to adopt this, but there is quite several challenging. One challenging is the complexity of the Snomed Ct and our capacity to understand and to use that. That is the big challenge. Another challenge is that to have the value proposition and the testimony to convince our policymakers to be the member, and we are close to that point. And we hope that in the next near future, we will be joining the Snomed Ct community.
So it would be incredibly good to have you. The one thing I would say, so I work closely with Liara. So obviously I do Liara's job for Europe. Mm-hmm. But also one of my other roles is around heading up global clinical engagement. Mm-hmm. Now, what we do, particularly in Europe and North America, and I'll work with Liara maybe to do more of this in Asia, is looking at running clinical sessions. So rather than a presentation like this, which is really aimed at a broad stroke of giving you information.
More marketing.
Which is more, this is marketing, where the sessions which I do around clinical engagement is not around marketing. Mm-hmm. It's more around really showing clinicians how they can change their behavior and the way they deliver healthcare to their benefit by using Snowmed. Mm-hmm. And I'll work, have a chat with Liara. If that's something which is of interest to you, that's something which I could do with one of my colleagues, who's Dr. Charles Guttridge, who works in London. Mm-hmm. Two of us run a number of those sessions, both for smaller groups, but also larger groups. I think the biggest group we've done it to is about 700. Mm-hmm. But we've also done it to groups of 30 or 40 people. But if something like that would interest you, have a chat with Liara, and then we can maybe make that happen.
Yeah, thank you very much. We can gather the interested audience to come to listen to that. I think that is the good strategy. The OMOP model is one that I think can convince a lot of specialists to influence the policymaker that this is be needed in the countries. So let's keep contact. I will communicate with you and Laila also. I think that would be the next project that we can do with in our region. Asian eHealth Information Network, AeHIN, can be the one that organizing those, and it will be benefit not just my country, Thailand, but also all the region, Malaysia, Philippines, something like that.
Yeah, I'd agree.
Okay. Any questions from another audience or comments? Okay, if not, thank you very much, Ian, for your very informative, and we hope that we can learn more about the Snomed Ct from you and the colleagues in the Snomed Ct International. Thank you very much for spend time and give us all the knowledge. Thank you.
It's been a pleasure. Thank you. Take care. Bye now.